Hi, this is Ron Broussard, and next we'll be covering Chapter 6, Lifting and Moving Patients. So what we'll be covering is just kind of the fundamentals of lifting in our day-to-day jobs and ways to prevent injury. So every call that we go on has some element of lifting or moving, whether it be a patient, whether it be an aid bag. If we don't do it the correct way, we're opening ourselves up to injury. I can tell you I went through the majority of my military career without hurting myself. And then I started working, and it was like as soon as I was on an ambulance, I like twisted to pull an aid bag and like pulled something in my back, and it was like the worst pain ever. And I still had to go on a call after that. So just make sure we're keeping in some of these techniques. Now, there are four basic body mechanics that we need to keep in mind. Uh, these enable us to be efficient in movement to gain a mechanical advantage. Good mechanics will minimize injury. One is keep the weight of the object as close to your body as you possibly can. You don't want to have to reach, bend over, or anything like that. Use the legs, hips, and gluteal muscles when lifting, all right, and not anything where you have to hunch over at the back. I've heard a joke goes like, "Oh, I'm getting old, gotta save my knees, lift with the back." No, we don't want to do that. Those leg, hip, and gluteal muscles are strong and provide a great foundation for us. Three is stack the shoulders, hips, and feet. So you kind of want to stack one on top of the other to make a solid base and build from there. And then four is reduce the height or distance through which the object must be moved. Good thing is moving our stretcher up and down. Okay, we have electronic lifts now, but then also doing things like getting a stool so we don't have to reach as far for, say, a high object. Now, this is one thing that you'll have to know for kind of testing purposes. Now, this is kyphosis right here, and that's the kind of posterior hunchback that you would see in the thoracic spine. All right, and then lordosis is this swayback type appearance of the lumbar spine. All right, and so we don't want to have excess of either kyphosis or lordosis because that can kind of put excess strain on the vertebrae and then on the disc between those vertebrae. Now, this is proper standing posture, and this is kind of what we mean by stacking. Okay, so notice the shoulders are stacked directly above the hips, hips kind of above the knees, right above the foot. Okay, proper sitting posture. I can tell you as I present this class that I probably don't have the proper sitting posture that I need, but we're still using that stack type approach with the ears directly above the shoulders, directly above the hips. Now, the one thing here with our sitting position is we want our feet to be flat on the ground. Okay, we want our feet to be flat on the ground. And then if we are not able to achieve that while sitting, we either want to lower our seat or place, something under our feet in order to have the appropriate foot position. All right, now with posture and fitness, good body mechanics cannot fully compensate for poor physical fitness. So we need to maintain a level of physical fitness to be in good shape when running our calls. Now, components of physical fitness include flexibility, strength, cardiovascular conditioning, and nutrition. Flexibility is, of course, the amount of stretch that you have in the muscle. Strength is your ability to move, say, an object or move weight with each muscle contraction. Cardiovascular conditioning has to do with your ability to move oxygenated blood throughout your body efficiently, and then, of course, giving your body the appropriate nutrients that it needs in order to function. Now, with lifting and moving, we're not alone in this. We need to work well in a team. And if you're not working coordinated in a team environment, that can open yourself up to injury. So, all team members need to be properly trained. Team members should be physically matched when lifting. All right. So, a good example of this is if you're, say, lifting a large patient and they're on a backboard. Okay. If you have four people doing the lift, okay, where you have, say, a strong person up at the torso or head, okay, on one side, you want another strong person to be on the torso head on the opposite side, because one, that puts added strain on the stronger rescuer because they may lift that person faster, but then also that puts our patient at risk of falling. Okay, communicate and coordinate throughout the lift. This is one of the things that I love, where it's like lift on 3, 1, 2. Wait a minute, are we lifting on 3 or is it 1, 2, 3 lift? Okay, make sure you work all that stuff out beforehand. Okay, tell the patient what you are doing. When you guys start backboarding in the class, you're going to feel what it's like to be put on a backboard and to be lifted up. Now, if you don't communicate to the person on the board, if anybody's ever been asleep and had the feeling of falling and then you kind of flail, that happens in real life. If you're not coordinating with the person and telling them, hey, we're about to lift you up, just be ready, they may flail and that may distribute the weight differently and cause excess to be put on one side or the other and put you at risk of injury and then, of course, at risk of dropping the patient. Now, general guidelines for lifting and moving. Know your abilities and limitations, all right? So this is one thing, we're in EMS, firefighting, I'm in the military. You see a lot of people who are like, I got this. I can deadlift like 340 pounds all day, no big deal, And look, weight in the gym is a lot different than, weight on a person, you know. Always have the appropriate amount of rescuers and don't overthink your abilities. Now consider the weight of the patient and of the equipment being used. Use an even number of rescuers and anticipate muscle fatigue. You do not want to be to the point where you're like you're carrying a patient using, a stretcher, and your like fingers are almost fully extended and your like pinkies barely holding it to where you're like, okay, we need to put the person down. Now, when you start feeling yourself getting fatigued, you need to communicate that, lower the patient, and then maybe switch sides. Do whatever you need to, but you don't want it to get to a point where you're about to drop the patient. All right, now here are some of the things that we can use as far as lifting and moving for lifting techniques. So we have the power lift. Now, a power lift gives best defense against injury, promotes safe and stable moves. And then within that power lift, we use a power grip. So the power grip is going to be palms facing forward. Okay, our palms are going to be in a supinated position. You are going to have your hand in full contact with the object, wrapping your fingers completely around and thumb around, and holding that object. Okay, that is the power grip. Okay, now with the power lift, okay, feet are going to be shoulder width or a little bit more than shoulder width apart. Okay, feet are going to be even with one another. You're going to squat down using the knees and the hips. Okay, avoid bending in the lower back. Okay, squat down at the knees and the hips to pick up the object using the power grip and lift the object. So here we go. We got our rescuers coordinating, of course, in this picture. All right, they're going to squat down using the power grip. Okay, now maybe we got a little bit too much curvature here, but you know what? Maybe this is demonstration purposes. Notice how her back's nice and straight. That's kind of what we want over here on this side too. All right, and then we're simply going to stand with the patient in the lift. Okay, so power lift, feet are even with one another, shoulder width apart. Okay, now the squat lift, we use the squat lift if there is some kind of maybe like an injury or we have one leg that's weaker than another. All right, so there's only a slight modification with the squat lift. The squat lift will take the stronger leg and place it slightly back, all right, for our lift. So notice our feet aren't even here. We got the stronger leg slightly back. Okay, when it comes to lifting the patient, okay, we coordinate through the lift, still using the power grip, okay, and we lift the patient. Now, general guidelines for lifting and moving, we have a one-handed equipment carry technique. No need to keep your back in a locked position. You don't want to use any kind of twisting, all right, or say overcompensation as far as leaning to, like, say, the opposite side. Maintain proper body mechanics. So those are, keeping the object close to you, using your knees, hips, and gluteal muscles. Avoid reaching. All right. And then avoid leaning to the opposite side to compensate. All right. So again, we're kind of more of a squat lift here. All right. Keeping the object as close to us as possible. Squatting down using the knees, thighs, or hips, and gluteal muscles. Back straight to pick up the object. Now, reaching. We've already mentioned this already, but we want to avoid reaching. We never want to reach more than 15 to 20 inches. This is in red. I would definitely know this. You will see this on an exam. Now, get as close to the object as you can, whether it be, you need a stool so you can get closer, just get close to the object. Keep the back in a locked position and do not twist. Reaching, again, is how you hurt yourself. Okay, now pushing and pulling. So whenever we have the option, we always want to push rather than pull. Now, if you must pull, you need to keep the load between your shoulders and hips. Keep the load close to your body. Keep your back straight and slightly bend your knees. Okay, so proper pulling and pushing technique. All right, now emergency moves. Now, we're going to show a couple different types of moves, like the armpit, forearm drag, the shirt drag, the blanket drag. The one thing you will need to know for testing purposes are going to be when you would use each of these moves. Okay, so the emergency move. We use the emergency move when there is a risk to the patient's safety or your safety. So you're in immediate danger. I want you guys to think about this like you got a vehicle that is on fire right now, and you need to grab that patient and get them out of the vehicle. Okay, we're not protecting the cervical spine. We are simply grabbing the patient to move them out because the scene is dangerous and could cause injury to the patient, to include death to them or to myself. Okay, so the scene is dangerous. We need to quickly move the patient. We're not necessarily worried about protecting the spine, just worried about getting the patient out of there. Okay, now here are some examples of emergency moves. So the armpit forearm drag, the shirt drag, and the blanket drag. Okay, now with the armpit forearm drag, now include those forearms because it helps keep the weight of the patient close to you. Notice how they're underneath the armpits here, and he's grabbing the forearms of the patient with his hands. Okay, shirt drag works great with collared shirts, probably not so well with t-shirts. All right, last thing you want to do is try to grab the patient by their shirt and you end up just with their shirt outside of wherever place they're at, and then the patient's still there. Then of course a blanket drag, so the patient magically falls on a blanket, can wrap them in that and then pull them out with the blanket. Now, urgent move. So this is where, again, a different type of move, different circumstance. So we would use an urgent move when there is immediate threat to life of the patient. They need to be moved quickly to provide care. Okay, I want you to think about this as the patient has airway compromise. They're not breathing. We need to do CPR on the patient. They have a major bleed that we can't get to. All right. So that is when we would use an urgent move. Now, with urgent moves, we would still, if needed, provide some kind of spinal immobilization. I'm not saying full backboard C-collar. I'm not saying that. I'm saying we would just have a provider hold the head in a neutral inline position to keep axial stabilization while we move that patient. Okay, so we use the urgent move when there is a risk to the patient's life, okay, such as airway, breathing, circulation compromise. Now, non-urgent move, we would use a non-urgent move when there is no risk to the patient's life, so airway, breathing, circulation's intact. Patient can be moved in a normal manner when ready for transport. So again, time is on our side. We can take time to immobilize the patient. That's when we use things like the Kendrick extrication device, the stair chair. We can use the tools that we have available because there's no risk to the patient. So some questions that you guys may see on exams are going to be along the lines of, you have a patient that has fallen down the stairs and airway, breathing, circulation is intact. All right, well, that's telling you ABCs are good. All right, we probably have a non-urgent patient here, so we can use a non-urgent move. Now, if you have a patient that has a massive bleed, okay, has breathing compromise, has airway issues. All right, now we need to use an urgent move where you come up to a scene, the car is on fire. Okay, now we need to use an emergency move. Now, some non-emergent moves: direct ground lift, extremity lift, direct carry method, draw sheet method. All right, so direct ground lift, simply saying we're going to pick our patient up from the ground, okay, utilizing this cradle type approach. Now, what you're seeing here, we kind of go against the body mechanics we've talked about in previous slides, but you still want to maintain and keep those in mind as much as possible. All right, so lifting the patient, and placing them onto the device. Okay, extremity lift. All right, so kind of using the armpit forearm drag, except for we have another provider that's lifting at the legs. And then placing the patient onto the gurney. All right, direct carry. So that's where we're lifting the patient from, say, a bed, okay, and then picking them up from the bed and then moving them to another bed, like our gurney here. All right, now the draw sheet method. This one we're going to use a lot. The draw sheet method we actually will use when we get into the hospital. We'll move them from our gurney to the hospital bed. Now, the one thing that I'll recommend is always have another provider on this side of the patient so you don't do one of those things where you pull the sheet and then the patient's still on the bed. That happens. So you want another provider here on this side so when you pull the patient over, the patient goes with you. All right, so we're moving from one bed to another. There we go. Now, packaging the patient for transport. Packaging simply means we're readying them to be transported. All right. Now, once the patient is stabilized, select and prepare a carrying device and move the patient to the ambulance. Now, also in packaging, make sure we secure, their extremities. If they're unconscious, we don't want an arm or a leg off the side of our gurney. If we're going to package the patient for air medical transport, we don't want anything that can become loose and possibly get blown away in rotor wash or get sucked up into the engine of the aircraft. So we want to secure things down in place. Also for air medical transport, we want to communicate with our patient and do any of the communication prior to moving the patient because once we're by the helicopter, we're not going to be able to talk very much anyway. All right, so some of the equipment that we have a wheeled stretcher. Now this can accommodate up to 650 pounds. Now we do have some limits as far as the terrain, so preferably we like to use this over smooth terrain. We want to make sure we always secure our patient to our gurney. Okay, well, a lot of times we have those 5-point harnesses now that will secure them into our gurney, and then we never leave the patient unattended. Okay, there's just a big risk for them to fall, so we never leave them unattended once they are on the gurney. All right, there we go. Notice they're completely secured in. Hands, arms are immobilized. All right, so we don't have any extremities outside of the gurney. All right, 2 rescue or stretcher carry. Now here's the thing, notice when we're going downstairs, we always want to go down feet first, or when we go upstairs, we'll go upstairs head first. Okay, 4 rescue or stretcher carry, all facing the same direction. All right, now this is the thing that I'm talking about here when you're using like a 4 rescuer carry. Like say we have a really strong rescuer here on this side, really weak rescuer here on this side. What we could have is when they go to lift this patient up, this patient or this rescuer may lift a little bit slower, may struggle a little bit more. That can cause some imbalance on the stretcher there and cause more strain on the stronger rescuer. All right, so roll-in type stretcher. All right, now bariatric stretchers. Bariatric stretchers are going to be for more morbidly obese patients. Okay, they're designed to hold up to 1,600 pounds. Now, these are great because they help us maintain a lower center of gravity. Okay, also they have these extended handrails, so we're not having to bend over because our gurney is lower. Oftentimes, these come with specialized ambulance to transport them in. And the ambulance will also come with a winch, possibly even ramps, to load that patient into the ambulance. All right, now a portable stretcher. This is useful to carry patients in confined spaces or for calls involving more than one patient. Now, with our portable stretcher, see it's kind of a lot smaller, a lot lighter. We can get it into these a little bit tighter spaces. Okay, provides a rigid surface for our patient to lay on. We can move patients one to another, drop a patient off, offload the patient from that, and then grab another patient with it. All right, so this would be an example of a portable stretcher. Okay, here's a pulled stretcher or canvas litter. Now these are great because these can be broken down. We use ones like these in the military, the Talon 2s, that these break down into like a backpack portable size stretcher. Okay, the stair chair. Now the stair chair is useful when a wheeled stretcher cannot traverse narrow walking spaces or stairs. Now we cannot use a stair chair for patients that are altered, okay, that have any kind of spinal injury or any kind of lower extremity injury. Okay, now kind of cover the stair chair a little bit here. The one thing I want you guys to remember is this equipment is available to you. Use it. So if you have a patient that's alert and oriented times 4 and you're trying to figure out a way to get them down the stairs because they're too weak to walk, we'll just say I've seen it to where it's like, oh, we'll just put the patient in this rolly office chair and then carry them down using the rolly office chair to the ambulance. It's like, that's not the right answer. You guys have this equipment, use it. Now, the great thing about this is we can completely immobilize, or not immobilize, but secure the patient to the device using a harness system. All right, so they're strapped into the chair. These tracks here will run along the stairs. All right, and so that way it's kind of like they provide resistance for us. So that way the stair chair doesn't slide down the steps really fast. All right, and then they also have these handles that even if you didn't want to use those tracks, you can carry the patient down the stairs. All right, there we go, using the stair chair with a spotter. All right, the stair chair with a spotter. Now remember, there are these tracks where you can simply lay the patient back onto those tracks, and then you could slide the patient down the stairs utilizing those track systems. All right, backboards. Now, we use backboards as a form of spine motion restriction and carrying. So you could think of backboards as a very large splint. Now, if I have like a multi-systems trauma patient that has multiple fractures throughout their body because they've been ejected from a vehicle, a backboard is a large splint. So when we don't have the time to, like splint up tib fib fractures, and other, distal long bone fractures because we have other interventions that need to take place, and we also have to transport the patient quickly to the hospital, we can utilize a backboard. Yeah, also with these backboards, they do provide a level of spine motion restriction. Now, we are going away from backboards for simple spine motion restriction due to the fact that we're finding patients are developing like pressure ulcers. They're uncomfortable, so patients end up moving a lot while they're on them. So oftentimes we get them to the hospital. We'll try to get that patient off of the backboard and they'll clear them at the hospital. But they're even having steps for you to do where you can clear the spine and just put the patient using a collar onto the gurney without a backboard. So some boards that we have a long spinal board, a short spinal board, vest type immobilizer, and a full body vacuum mattress. Okay, here's a long board. Now this board has a mitered end to it. This mitered end will work well to fit in a Stokes basket. There are also ones that are just completely rectangular. I've seen those in my military service. I will tell you guys to be aware of the equipment you have, along with the compatibility with, uh, say, air medical evacuation. Situation that I had, we had an injured soldier, and they were injured in an airborne operation. We ended up providing care, stabilizing them, and putting them on a backboard. We did not have a mitered backboard. We had one of completely rectangular backboards. And so when the helicopter came, it was a civilian helicopter that came to pick up our patient. When they went to load the patient into the helicopter, our patient wouldn't fit because our backboard wasn't compatible with their system because it wasn't mitered. So we ended up having to move the patient from our backboard to a backboard that was brought out by the fire department and then loaded on. So imagine, what that put the patient through that had, femur fracture and all kind of other stuff going on. We had to move them more. That caused more discomfort for the patient. So just try to know some of the capabilities and limitations of the equipment that you have. Okay, the Kendrick extrication device. So this is kind of a short type board. You guys will practice and train with this in the class. This can be used to immobilize seated patients. I would say this would be a great tool to use for a non-urgent move. Say you have a vehicle collision, the patient, there's a risk for spinal injury because of the mechanism of injury. However, airway breathing circulation is intact. All right, we can use this to immobilize the patient in that seated position and then move them safely, keeping the spine intact, out of the vehicle. All right, so full body vacuum mattress can be used for immobilization of patients. So in a sense, put the patient on the vacuum mattress, you remove the air from it, and then it becomes rigid and conforms to the patient. Okay, the scoop stretcher. Now, the scoop stretcher can be assembled and disassembled around the patient. Good for, like, say, getting your equipment in to build up around the patient and then remove them. One limitation I would say with this is, if you're having to take it apart to get it into your area, you might not be able to remove it while it's assembled. We do not want to use this for patients with spinal injuries, but this is great for patients, say, with like pelvic injuries, where we need to build the stretcher around them and we don't want to roll them to one side or the other. Hey, it looks something like this. Okay, so we can build this around the patient. All right, the basket stretcher, also called the Stokes basket. Okay, now these are great for moving patients under uneven or sloping terrain. All right. So if you see this on an exam, like which stretcher would be great or which equipment would be great for moving patients over uneven terrain, it'd be a Stokes basket. Okay. Think search and rescue with these. Okay. You can take this and you can use it and place it onto your wheeled stretcher. Also, you can take your backboard and like if you have the patient loaded onto a backboard and then load them into a Stokes basket. You can also hook these up for air medical, like where you have to hoist a patient. Just make sure you have a stabilizing line. You can YouTube videos of uh, where they don't have the stabilizing line, and then you got your patient that's spinning around like a propeller. That's never good. All right, but a Stokes basket, great for moving patients over uneven terrain, perfect for search and rescue. All right, other equipment, you have the flexible stretcher, also known as the Reeve stretcher. Now, great for constricted spaces. However, we cannot use this for patients with spinal injuries. Okay, so if they have any kind of spinal injury, we cannot use this because there's no rigidity in it. Therefore, it doesn't provide any kind of spinal motion restriction. Okay, it looks something like this. The handles, okay, great for you to quickly move patients. However, it just doesn't provide a lot of support for the patient. Okay, so click on the best device for moving unresponsive patient from an upstairs bedroom to the ground floor. All right. So, unresponsive patient, upstairs, ground floor. Now, they're unresponsive. So let's just take 2 out right now. The short backboard, okay, is like only torso size. So if they're unresponsive, the last thing we want is for their legs to be flopping around, okay, while we're trying to take them downstairs. So that's gone. The stair chair. Remember, they cannot have altered mental status to use the stair chair. So some of you guys may have been thinking, it's like, oh man, the stair chair, we can use that upstairs to downstairs. Perfect. No, because they're unresponsive. All right, that leaves us 2 options. We have a wheeled stretcher and a scoop stretcher. All right, now we could use both of these, but if you think about your wheeled stretcher and you think about your scoop stretcher, we have to move a patient from upstairs to downstairs. That scoop stretcher, it says nothing in here about spine injuries. So that scoop stretcher is smaller. You can bring it up, carry it around the patient. That's a lot less weight that we're then needing to carry down the stairs. All right, so correct answer would be scoop stretcher. All right, patient positioning. Now, patients are most commonly placed in a supine or a sitting position. Now, special considerations based on patient conditions include, so we're going to go over some of the different ways that you will position a patient. So, position of comfort. Oftentimes, this is going to be similar to the sitting position, where the patient's sitting in a Fowler, so 45 degrees, or a semi-Fowler, about 30 degrees, kind of recline back a little bit into a position that they're comfortable. These patients are going to be more your like difficulty breathing patients. All right, we're just going to put them in a position in which they're comfortable. Now, supine position. Supine is laying flat on their back. All right, this is also going to be the position we'll put patients in who are like hypotensive, showing signs and symptoms of shock. All right, that way we can get a good even distribution of blood to their brain. Their body's not having to keep more pressure to get blood flowing up to their brain. We lay them flat. Okay, if we're having to ventilate a patient, okay, we will lay them flat. All right, so understand supine, shock, breathing issues where we're having to breathe for them. All right, with a bag valve mask, we'll lay them flat. CPR, they're going to be in a supine position. Now, position on left side, which is the same as left lateral recumbent position. This is going to be, altered mental status, no spinal injuries, all right, where vomiting is a possibility. And if they vomit, they're on their left side, we protect their airway and decrease their risk for aspiration. Now, infants and toddlers, we just need to make sure we have the appropriately sized, we have, I can't think of the name of it. It's a harness system that attaches to our gurney that enables us to use our belts to immobilize or to secure a toddler to our gurney. Also, with infants, we can use a car seat on our gurney, just ensuring that we hook it up appropriately to the gurney. Now, pregnant females, we need a kind of pad under one side. Okay, so just raise them up about 10-15 degrees on one side if they're supine. All right, so we don't want them to be true supine because we put them at risk for supine hypotensive syndrome. Okay, supine hypotensive syndrome. That's where the weight of the fetus puts pressure on the inferior vena cava, and then it decreases blood flow back to the heart. Ultimately, what it does is it decreases our overall blood pressure and causes a decrease of blood flow to the patient's brain, causes hypotension, of course, but then lightheadedness, dizziness can cause some vomiting. So we want a pad under one side to kind of tilt up their hips to take pressure from the fetus off of the inferior vena cava. All right, elderly patients. Now, this is where, if you guys remember back to earlier in this chapter, we have to account for some of those anatomical changes that happen, like kyphosis, where we have that kind of hunchback appearance, or lordosis. We just want to ensure that we are padding in the voids. Okay, so if our patient has like kyphosis, we're wanting to pad their head. We're not trying to straighten them and flatten them out onto like a backboard if we needed to use that equipment. And now, patients with physical disabilities, that's where we're looking at, say, protecting extremities. Like if a patient is like contracted, again, we're not trying to force, like any body part to, anatomical position if they're all contracted up, but we want to protect those extremities so we don't injure them further. Okay, so make sure we're padding appropriately. Make sure we're utilizing, the pillows, blankets, whatever we need to do uh, to protect that patient. Like a good example, the other day I had a patient that had kind of some hyperflexion going in his neck, so his head was flexed down in a like a chin to chest type appearance and kind of rotated. Well, we ended up providing some padding underneath his chin, in a sense, to help kind of keep his airway going, but then also to kind of keep his head so it wasn't just falling down because he wasn't able to support his head. So again, we're just taking into account their condition and trying to make them comfortable and protect them from further injury. All right, now air transport, we kind of talked about this already. Decontaminate the patient. That's if there's any kind of hazmat. Now, hazardous materials specialists will be assisting with your decontamination process. The last thing you want to do is put a patient with hazardous material on them into an aircraft where it causes the pilot flight crew to become disoriented, and then you risk crashing an aircraft. Okay, manage the airway appropriately. That goes with anything. Okay, leave the chest accessible. Secure all equipment. Communicate with the patient. Make sure this is all done prior to getting under the rotors. All right. Cover the eyes, ears, and exposed wounds. Okay, one thing that we'll do, like the helicopter crew, they'll come out and they'll make contact with the patient away from the aircraft. Okay, they'll give them a headset, like some ear pro to put on, some eye protection to put on. Okay, before they go under the aircraft. I've had STEMI patients. They'll come out, still give them a headset, all that stuff, just so it protects them from like the noise. Okay, and then listen to the directions of the flight crew. They're going to tell you what to do, how to approach the aircraft and everything. A lot of times they'll walk you up to the aircraft. Just follow their commands and it'll actually goes pretty seamless. Now, neonatal isolate. This is going to be used for transporting our neonatal patients. So those are patients from birth to 30 days. Okay. Now this attaches to the stretcher mounts of the ambulance. Now, what the neonatal isolate does is it creates a kind of an internal environment for that baby. Now, neonates, you know, uh, their immune system is still developing. Their pulmonary tissue is very fragile. So we are at risk of a lot of different things like pneumonia or sicknesses. Not only that, but they're at risk of losing heat. Okay, they have a lot more surface area than they do mass. So these create like a kind of a controlled environment where you have a temperature control. You kind of limit exposure for that baby during transport. Okay, so that concludes the class. Okay, we covered lifting and moving patients. Okay, we do this on every single call that we go on. Now, make sure you are protecting yourself and using proper lifting techniques. Okay, know the capabilities of your crew and of the equipment. Okay, and then always exercise safety for yourself and your patient. Okay, guys, if you do that, if you think, how do I protect my patient? How do I protect me? And you always act in the best interest of your patient. Okay, that is a great start to any process. All right. All right. That concludes the class.